I don't, okay, there we are. Yes, meetings being live streamed.
All right, do the intro.
All right, hello everyone on Facebook land. Thank you guys. This is yet another happy office hours. And don't ask me which one. It is September 5th, and we are joining you here in Zoom land and to Facebook land. And this is CalCare Office Hours, which is a joint labor of love from Healthcare for All Los Angeles and PNHP SoCal. My name's Jeanna Harris. I'm your favorite neighborhood friendly nurse. And right now I'm joined with my tech extraordinaire who's hosting and going live, Paul Newman. And then there's Dr. Bill. Hey, Dr. Bill. So so we'll get started here and we're going to give it a couple more minutes just for let people get on here and for me to share because I don't know what browser I'm even up on right now. So we will get started here with our lovely show. We are live. It is September 5th. Can you guys believe it's September 5th?
It is. And
where did this, where
we
is
are
this
live on Facebook. We're Facebook Live.
Where is this year going, everyone? Someone tell me, where are we at? What happened? And with it being September 5th, you know, we're also, you know, coming into fall, which brings up the good conversation of COVID. And Dr. Bill, chime in with me while we kind of just wrap a little bit for the next few minutes. What are your thoughts about the fall season, fall, winter, COVID, flu? You know, I'm worried that this anti-vax conversation movement that has been kind of building over this year with the COVID vaccine will also make people not want to get the flu vaccine, which, you know, people still should get to protect themselves, because I think that as we're coming back in person, I know we're going to have in-person holidays. I'm concerned of a potential flu outbreak that will mimic COVID outbreak because the symptoms will all appear similar. So I kind of am, you know, curious on what your thoughts are as an ER, you know, physician.
Well, absolutely, Jeanna, and I'm happy to share, although my browser is acting weird now too. I don't know what's going on here with the browsers, but can't get over to my browser. How strange. But I know some 40% it's estimated of all COVID. First of all, you know that the US is the world leader of COVID deaths. We are the gold medalist in COVID deaths, right? Of the Olympics of COVID, we have taken the gold medal. We still are holding the gold medal of COVID deaths. I mean, despite the fact that we don't have the largest, most populated country in the world, right? So India's larger, China's larger in population size. We still have more COVID deaths than they do. You know, India, you might say, well, they're all kind of, it's a repressive culture. They all follow strict instructions, you know, all that stuff, right? So, you know, they don't have their freedoms. Well, guess what? Our freedoms, are they costing us more deaths? You know, that's a good question. But India, you know, okay, so they have wider economic disparity, perhaps. I don't know, but they do have more universal healthcare than we do. And that's really where we're going. We don't have universal healthcare. So the only part of universal healthcare that we've had to deal with COVID has been vaccines. Vaccines have been the only part of COVID that has been universal. And guess what? Because of misinformation, a lot of people are turning those down. They're turning them down because they don't have trusted sources of medical information, like a doctor or another provider, you know, a nurse practitioner or physician assistant would be fine, a good primary care source of information. Instead, they're getting their information from the internet or cable TV news, which is a terrible way to get, you know, trusted or trustworthy information. What you want is a trusted source, someone you can go back to, you can ask questions, you can, who listens to your questions and answers them in a way that you understand. We don't have that in this country. In Japan, they see their doctors on average 13 times a year compared to our 4 times a year. Who are you going to trust? Someone you see 13 times a year, someone you're going to see 4 times a year. So that's the problem with COVID in this country. Some 40%.
Echo. Sorry about that.
Yeah, some 40% of all COVID deaths would be prevented if we had a universal healthcare, a single payer system like what we're talking about with AB1400. 40%, that's almost half. In California, that's about 65,000 people who have died, I think now. I was trying to get to my browser. Let's see, now I can for some reason. I will post.
I think we're about 65,000 nationwide and some change.
650,000.
600. Yes, I'm sorry.
Yeah.
I took some away. I took several away. Oh,
yeah.
That's so sad.
So we're about a tenth. California is about a tenth of the country, 10%. So the country is about 650,000. That means we're about 65,000, and that means that close to 40,000. Oh, let's see, about half. So 35,000 of those deaths in California would be prevented if we had an AB 1400. 35,000 deaths. That's like an Anaheim Stadium filled with people. Almost that did not have to die due to COVID, and that's ongoing. People are still dying. Universal testing, contact tracing, all those things that put us at risk for COVID, like having untreated diabetes, heart disease, high blood pressure. Those things make us more at risk for COVID and other infectious diseases, right, Jeanna?
Absolutely.
So if we had those things adequately treated, then we wouldn't be the world's leader anymore in COVID deaths. So thanks for asking me about that. And this one Delta variant, I think it's subsiding at this point. Our most experts think that it may be subsiding at this point, and certainly when we get kids vaccinated, ages 11 and below vaccinated, hopefully that will really suppress the virus. But if we don't, there are more and more infectious variants yet to come. So we may not be done with this pandemic yet, unfortunately, especially leading into the winter months.
Yes, thank you, Dr. Bill, for your feedback on that. I really appreciate it. You guys know we always have a COVID soapbox that I like to talk about because it's always very important information. And we'll continue to have soapboxes as long as COVID is a problem. So if you don't want to hear our COVID soapbox, please don't make COVID a problem. Make it a thing of the past. Make it something that we'll sit around the fires with our grandchildren and talk about the before 4 times. I remember before when I can get on an airplane without a mask, and now I wouldn't dare do it. I think that mask is part of my now forever wardrobe. So, Dr. Bill has brought up a lot about AB 1400. And for those of you who could be joining us for the first time, I want to welcome you to this space. This is an office hours, much like in college where your professor would say, hey, my office hours are from 5 to 7. Stop in if you have a question. That's exactly what this is. But let me tell you what CalCare is. Why are we doing this? Why are we dedicating our time for free as a labor of love for this bill? So I'm going to go over what I like to say is my CalCare keys to success. I'm going to share a screen, maybe. Oh, I had this so flawlessly done for the first couple of last few meetings. This happened flawlessly. I was overdue for it to not work. Okay, here we go. All right. So Paul, can you guys see my screen okay? Great. All right, so CalCare. We're talking about California Guaranteed Healthcare for All. It is a bill in the Assembly called AB 1400. And it is exactly what I just said, guaranteed healthcare, emphasis on the all. And it is the solution to our broken healthcare system, which I think we all know is really broken. So I, want to go over the 7 basic principles, and I would be remiss on this Labor Day weekend if I didn't give a shout out to the union who A, provided me with this graphic, B, helped write this bill, and C, is somebody, a group of people that you probably love very much so because they're nurses. So I want to give a shout out to the California Nurses Association. Thank you guys so much for continuing the fight. Nurses rock. We're the most trusted profession, and we are the ones who interpret everything that you don't understand that the doctors say. So anyway, going into California, the guaranteed healthcare for all, it is universal coverage. We are talking everybody in, nobody out. Emphasis on nobody. That means if you have a body and you are in California as a resident, you are in. If you do not have a body, I am terribly sorry. If you're a celestial being, you're a ghost, you're related to Casper, you do not get CalCare. I am so sorry about that. But everybody, regardless of your race, sex, gender, country of origin, disability status, immigration status, marital status, age, and income, gets the care that you need regardless of ability to pay. Conservatives will probably go really crazy of this last little sentence, regardless of ability to pay. And you know what that means? That means that we as a society want to see each other well. We are a community, whether we like each other or not. A single public program, we're talking single payer, publicly funded through progressive taxation. What does that mean, progressive taxation? Don't focus on the word taxation as much as you should focus on the word progressive, which means that if you make a little more, you get taxed a little more. And that's not that terrible, because I'm pretty sure if somebody that's a multi-billionaire gets taxed a little bit higher than somebody who's basically making minimum wage, struggling to make ends meet, they won't have to lose their house if they have to pay a little bit more on the billionaire side. They won't even basically notice it pretty much, but they will notice it just because they are being told that it's there. Will they notice it being there? Probably not. But this is to cover all necessary care in California. This is going to eliminate billions in bloat and waste and save people thousands on their healthcare costs. And you're like, well, Jeanna, how does this eliminate billions if you're saying that we're going to be taxed? Well, let me tell you, part of my job as clinical case management is calling these insurance companies and getting the benefits, getting the reviews done, getting the denials reversed for your care that they're denying. And I spend a lot of time unnecessarily just having to sit on hold, to deal with their computerized phone trees that don't understand the words that I'm saying and keep telling me that they don't understand that. And I get paid quite a decent amount to do it. And if I didn't have that, if I had a single payer system, I would not have to spend that much time on the phone. I have to spend my lunch on the phone with health plans, where I could be going on and taking care of the next patient because I know where this payment's coming from already. I know the guidelines that are needed to have this care, paid for and approved, because it's a single payer system. Every plan has added their own little nuances. And let me tell you, there's over 100 something plans in California. So there's no way for me to know that. So yes, I have to keep calling and calling and calling. Well, Jeanna, what about going online? Couldn't you go online? You would think they put all that online, but they haven't. So that's where we say eliminate billions in bloat and waste. I just gave you a small example. And then we're going to save you thousands, because then they may not need as much of this to happen. They may not need, to have to bloat and pad costs to pay for people to sit on the phone and fight insurance companies if the insurance company isn't there. They may not, so they're saving you thousands because we're going to streamline, as Bill just put in his background, what I call the spaghetti bowl. If we streamline this spaghetti bowl, that eliminates the holes where all the extra costs can fall through. So that's where we say eliminate billions of bloat and waste, and we're going to save you thousands because of that. We're talking fully comprehensive benefits. This includes medical, dental, hearing, vision, mental health, very important, prescription drugs, long-term care, and more. So this is actually Medicare to the extreme. This is better than Medicare, okay? Because Medicare doesn't really cover the dental, hearing, vision part too well, nor long-term care. And this is going to cover that. All decisions about your care will be made between you and your doctors and nurses, not insurance companies. Well, how is it that the insurance companies make the decisions about my care? Well, for example, you may need something. You may actually be admitted to the hospital right now, and you may need something done. And the insurance company has sent us a denial already saying that you're ready to leave the hospital. So somebody like me hops on the phone and says, hey, you know what? I got clinical justification right here saying this person's not ready to go. And they're like, well, we're still denying it. So then I have to get my physician. So I have to take my physician off away from patient care to get on the phone with the health plan's physician who has never seen you, who is basically just reviewing papers about you, to talk, to do a peer-to-peer so that then they can at that time determine whether or not they're going to cover you. And they still may deny you. But once again, bloat and waste. Why is it that that medical director of the health plan decides whether or not you get to have that surgery right then and there? We're saying you need it. Your health plan may not say that. Your health plan may say, you know what, we think you can wait. We think that this can be done as an outpatient procedure, which will delay that procedure by weeks, maybe even a month, depending on how backed up that surgical center may be. So you see what I'm saying, people? Anyway, I'm gonna keep on moving because I feel like I'm going down rabbit holes. We're talking fully, like I said, and then that goes on to the fully comprehensive benefits about the decisions of care. So now we're saying freedom to choose your care provider. Under CalCare, there will be no more in-network, out-of-network. So if you have a primary care doctor that you're not too fond of right now, and you have know of another one that you want to go to so badly, but they're not in your network, guess what? That doesn't exist anymore. You will call that other doctor and say, are you seeing new patients? Or do you have availability? And if they say yes and yes, you schedule that appointment, you go to their office, you show them your CalCare card, you fill out your new patient information forms, you have a seat, you get seen, and then you leave as a happy person with a big smile on your face. Isn't that great? So you will choose to have the freedom to choose any doctor or hospital you like. Point blank, period, done. And that goes into the next topic. Free at the point of service, no copays, premiums, deductibles. You go to your doctor's office, that new doctor that you're excited to see, you show them the CalCare card, and then you have a seat. Okay, have a seat. Doctor, see you soon. Done. Point. No more. No mas. And then you leave. And if you have a prescription in your hand, you're going to take that prescription to the pharmacy and you're going to show them your CalCare card and you're going to get your medications. And done. No more trying to sit there and figure out, well, can you tell me how much this is going to cost? Or, that's what happened a lot with the COVID vaccines. People did not believe that the COVID vaccine was truly free. They thought that, and this is from their words, I did vaccines, that they thought that they were going to get a bill later. They thought that they would they thought I was just BSing them and telling them, no, it's really free. You're not going to get a bill. And they're like, no, I know I'm going to get a bill later, because we are so brainwashed to know that everything we get has to be paid for. That we could not believe that this was a truly free thing. That was just a little simple sample of what single payer actually feels like. What people in other countries, less industrialized countries, less rich countries feel every day. It's incomprehensible that we over here are paying this much for healthcare. They don't understand that. They're like, what do you mean? That doesn't make sense to me. If you have friends who grew up in other countries and came over here for whatever reason, Lord knows, but jobs, whatever, them having to pay for healthcare may be a little bit of a culture shock. I've seen it happen. They're like, I don't understand. Why do I have to pay just to see the doctor? Like, they could understand maybe paying for a medication, but they couldn't get why they had to make that copay to just to see the doctor. For us, that's kind of normal. We're like, oh, okay, $25, here you go. Oh, okay, my medication's $35, here you go. We're robotic, like almost robotic with that, where it's just normal life here, but it's not supposed to be that way. And so what happens to the health and insurance industry workers? With it being especially Labor Day weekend, we want to focus on the worker because labor is so important. The labor movement is so important. I did a show about this earlier today about why labor is so powerful and why it took such a big hit when corporate America went off the rails and got so much steam, was put on steroids in the 70s and 80s and beyond. Because they were basically taken off the leash, and the labor movement took a huge hit. But because labor helped write this bill, they included just transition, which is funding and programs to protect and support any displaced workers in the insurance industry. That is what labor can do. Labor is powerful. They do look out and for the worker. They are your ally in this very kind of unjust world that we're experiencing right now. And then lastly, patient care based on patient need. No more financial incentives to avoid providing necessary care, including value-based payment models for providers. And going back to what I was saying when I had mentioned the insurance company doctor having to talk to the doctor taking care of you, when I said that they may feel that you could have this procedure that the doctor's asking to be done now later, that is the financial incentive to avoid providing necessary care. They're saying to save money to get you out that hospital bed that they're paying thousands and thousands a day for. They'd rather have you go a longer route, take you on a long detour to that care to save those few dollars then, but at the same time, you may be getting sicker. That condition could be getting worse. But they're saving that money in that short-term money. They're not thinking that if you got sicker in that time where you were trying to get this procedure done outpatient, how much money they would spend because you had to come back to the hospital anyway, and now you're sicker. They're just thinking of that short-term money right there. Well, we got them out the hospital, we saved right here, but we blew the budget because you got sicker, because they couldn't get you back in a week or 2 weeks that you needed to get back in. And now you're sick, now you're in the ICU, now they're paying out more money. So you see, waste, bloat, and waste. Anyway, that is the 7 basic principles of CalCare. And once again, I went way longer than I wanted to go, but I hope you enjoyed that. And I hope that you guys understand this is presented by CNA, and it is a very good one-sheeter. I love it. I'm going to stop sharing now, and let's get into, some questions. And I see that we have questions in the chat. I see one from Jeffrey. I'm not going after the last name. We're going to say Jeffrey T. California needs to do universal testing to see, through throats or saliva spit testing to see which of the 40+ million have COVID-19 exposure still to come, or more still to come. So that can be, anticipatory testing, surveillance testing, but, people at the same time still have to participate. And what we're facing now is not just the availability of resources. We've actually got the resources. It is like before we didn't have the resources, before we didn't have those PCR swabs, available. And so getting a test was like virtually impossible in the beginning, unless you really, really look like you had COVID. But now it is unfortunately I don't know. I'm not going to say any mean words, but I think that surveillance testing is also a issue of will, And then Dr. Bill, do you want to add to that?
I do, and thank you, Jeffrey. I'm glad you brought it up now. I think you were meant to bring it up in a previous town hall, but I think you can look at the problem with testing. And this is not just COVID. This is also has to do with screening tests in general, medical screening tests. For example, the practices of non-invasive imaging, MRIs and CAT scans and that kind of thing. In this country, as like Jeanna said, why aren't these things more available? And that's because they've been based on their market ability, that our health is seen as a commodity, as something to sell, and not a condition of human need in this country. And that is true of the testing. If you look at most universal healthcare countries around the world, early in the pandemic, they offered universal testing. Whether it was, saliva, nasal mucous membranes, PCR testing, blood test, whatever it was, whatever testing that suited the purposes at the time, they offered those things as a matter of public health with public resources due to public need. We didn't, because none of those things were public priorities in this country. And that started us off on, it's like being in a relay race and someone, you reach for the baton and it's not there. They drop the baton, and it took you months or a year, or we haven't even picked up the baton yet because we don't even know the extent of the disease. I mean, how many people do you know who've been tested on a regular basis in this country? We don't know the extent of COVID in this country. In South Korea, they knew how many people had the disease there all across the country within days, if not weeks, of when the outbreak first occurred. And they had all of those tests made available because they could allocate those resources. They said, this has to be a high priority. The other thing they were able to do was to prioritize resources to share medical data so that clinics and hospitals could, appreciate how much data was coming in from this area, how much from this area, how many people were actually sick with the disease. In this country, that information is blocked for proprietary reasons by insurance companies. They don't want, their competitors to know how much traffic, what the actual needs are in the different communities. So they block that information. So one hospital doesn't know how much COVID is going on in the hospital next to it. I mean, there are statutory requirements for reporting infectious diseases in general and that kind of thing, but they are not sharing the information. This is universally expressed among public health authorities that we're not sharing the information in this country well enough to really understand the extent of the disease. If you look at a country like, Cuba, especially these island nations, but Cuba is probably the best example because they're used to surveying their entire country, their island nation, and they'll go out and talk to millions of households. They send folks out like surveyors or census takers. They call them social workers, but they're just going out and getting information. They want to know, do you run a refrigerator that's not energy efficient or have old-fashioned light bulbs or whatever? They find out that information. So when you are able to get that information, then you can, set up systems to take care of that. And we didn't have the systems set up even for the universal part of this pandemic, which was, as Jeanna mentioned, the vaccine. We didn't have that available. So now we're looking at catch-up. If we have a saliva test, I took a saliva test more than a year ago. It was a home test that you could get for free through the county where I live in Orange County. You could just send away for it, and they send it to your house, and in a return, you could send it back in a return envelope. You got a result. Now, what does that mean? That one result. What does it actually mean? Well, it's hard to say. It's hard to put it in context without seeing your doctor or without knowing exactly what kind of test it is or related to if you have symptoms or not. Hard to know. It's hard for any one person to interpret. So it's a really good question. Which test is best? At what point, in your particular situation? All I can tell you is that with a system like AB1400, we'd be so far ahead. We would be, California has the 5th largest economy in the world. We would have health outcomes like those advanced countries in the world, despite what the rest of the United States is suffering with right now. And we are a little bit better than a lot of other states, as we know right now. Texas, Florida, Idaho, they're not doing so well right now, okay? But we're only a little bit ahead of them. We still have way too many deaths, because of these priorities not being based on. Just one more thing, Jeanna. President Biden himself the other day, in talking about negotiating down drug prices, which is a part of AB 1400, just like national Medicare for all, or even this Medicare expansion that's going on the federal basis. AB 1400 does this as well. So California, as a major purchaser of prescription drugs, like you said, won't cost you anything. You take your prescription to the pharmacy. California will buy your prescription drugs. As a major purchaser, it will negotiate drug prices with pharmaceutical companies. And those prices won't be based on a market, share, won't be based on what they can get for the market. It'll be based on the needs of the people of California. And President Biden said the same thing the other day about Big Pharma. He said, Big Pharma costs, prescription costs, can no longer be dictated by what the market will allow. It has to be based on what conditions of the people dictate. So that's progress, and it exists in AB 1400.
Exactly. It's a collective bargaining structure. The more collective you have, the better bargaining you get. So I just want to jump to China, who put a good question in the chat. And, she had said that she's in favor of single payer. And you know what, China, if you want to come off of mute, you're in the Zoom, you can feel free to come off mute and address it. I feel like I should read it though, because you typed it up so long, but feel free to, go ahead and ask your question. And welcome, by the way.
Oh, thank you. Can you hear me?
Yeah, we can hear you.
Okay, wonderful. Yeah, so I'm asking this because I work for a community health center that does contract with health plans. And so, my question is, the only place in the CalCare text that addresses health plans is basically to say that it allocates money for essentially paying off anybody who's laid off from a healthcare plan. From a health plan, if they're currently employed. But since health plans exist not just for enrollment and taking premiums and paying out, they exist also, to contract with medical offices to ensure, quality and safety standards. I wanted to find out if there's any room to transition the role of health plans instead of creating the shock of immediately eliminating the need for them, and whether there's any transitional role they might play, perhaps in either handling billing for the state. Now, the state would be the one to handle any medical bills, or, is there any role in continuing to handle safety guidelines if they're not handling enrollment?
Yeah, that is, I actually really do like this question because it hasn't been talked about enough. And that goes into kind of this just transition that is written into the bill, but not very detailed. And so to broadly answer, and I'll go a little bit deeper. To broadly answer, AB 1400 is, I like to call it the framework, right? So it doesn't get too deep on anything, really. It gets deep into benefits and things like that. But when it comes to like rollout, you'll see a lot as referred to the board, this 9-person board that gets built as soon as AB 1400 passes. The board that gets appointed, the 9 people, hopefully more. I'm hoping that we can get a few more people added to that 9-person board, because this is such a big entity that I think more than 9 people should have that much power. But, they are the ones that are going to sit down and really hit these, like, kind of like, if this is the framework, the 9-person board, and then there's going to be an 11-person advisory committee, that these are the people who are actually going to be sitting there building this house out, picking what the drywall we use, picking the colors and everything. They're going to be the ones that actually build this out. They're going to be the ones that apply for the waivers to see if we can get the federal funding. So there's going to be a lot that the board and that the advisory committee will start to work on, such as what you're addressing, like how do we do a transition? It cannot just be, you're right, like the shock of unemployment. It can't just be AB 1400 passed on February 1st and everybody in the insurance industry was unemployed by February 28th. No, that can't happen. And we're very well aware of that. I know we sound very anti-insurance industry, which kind of are, but at the same time, I always say it is not the penalty of the worker to have to suffer for bad leadership. I used to work for the industry, so I very much so understand what could be at stake here. So when it comes to transitioning, I do believe that the health plans will find a way in, which is by the ways that you, like what I'm thinking that they're going to be able to do is exactly what you mentioned, trying to handle billing, because they are, even though it is, they have worked in their ways of profit and to make it gainful, to get their profit margins up, their ways of handling billing and their systems are not something that was necessarily public. So could the state find the best one to work for them and then pair up to get that access to that system and that billing structure? Possibly. That's a possible way that they could have in, but the thing is, the motive will no longer be profit. And that is what's going to really help break this apart and make this, even if we have to deal with the insurance industry some way, somehow, when the motive is no longer, they're answering to the people of California and not to the board of directors of Anthem and to, all these other insurance companies, because that's what, at the end of the day, that's what their leadership answers to. They're not answering to their patients or their members. They're answering to the board of directors, and the board of directors wants to see profit. They want to see projected growth be met. Whereas with CalCare, when we have a publicly funded system now, we want sustainability, yes, but profit is not necessarily the driving force here. We want sustainability, we want affordable care, we want quality measures met, value-based measures met. But we're not sitting there saying, well, we have to report this to our stock or our shareholders in the stock market, what like the private insurance industry is driven to do. So like, I do see that there will be some merger in there and that they will be able to weave in. On top of that, I always like to say they have opportunities to create buy-up plans. CalCare is guaranteed healthcare for all, yes, with the basic needs, and actually more than basic, but cosmetic stuff that may not be medically necessary, they could have an angle on the market there. They can create buy-up plans, people who would want to get more cosmetic stuff done and can have a buy-up Anthem plan for cosmetic. I don't know. I know that sometimes some other countries who are semi-private or have a public system with a private option, which is completely opposite of here. It seems like we more so have a private system with a public option, barely public option. That public option is only if you're, under poverty lines or if you're, elderly or disabled. But we have a kind of an opposite system, but you can buy up. And I could see that happening as well. So there are some options there, and there is space within AB 1400 for that to be built out. And I think that's another reason why it is really broad in certain instances. Some instances it's a little bit more defined, especially when it comes to what AB 1400 is going to cover. But a lot of it does get deferred back to this board for that reason, because it does need to be built out. And I can't emphasize enough that we can't even build this dream until they pass this bill. So the emphasis here is that I need them to pass AB 1400 prior to us being able to build this out, only because if we can never build this out, I will never be able to answer that question you just asked. And so we need the elected officials to allow us to just build, because we can't, in the bill, you can't implement it until the board gives that thumbs up. We're ready. We've got the plan. We've got it sustainable, and we're ready to go. We've got Health and Human Services. Okay. We got the Secretary of Treasury. Okay. We checked all the boxes. Thumbs up, we're ready to go. And that's probably, realistically 5 years from when that bill passes. But until we get this passed, we can never build that out to answer exactly those questions you're asking. I have to just speculate, because nobody will let me sit down. I'm appointing myself to the invisible board now. Just FYI, Governor Newsom, you want to appoint me. But yeah, so, to sit on that board to work this out so that I can come back and say, you know what, this is what CalCare is going to do. This is how we're going to do this transition. This is what just transition looks like. This is how the insurance industry, we're going to use this billing structure. We're going to do this, we're going to do that. These specific questions can't be really answered until they say, yes, AB 1400, now board and the committees go build this out, and then come back with, and we'll answer these questions and work this out. So it is a fight. And I'm sorry, I was extremely long-winded with that, but I hope that semi answered the question.
Can I chime in on that?
Sure, Dr. Bill.
Because it's not, while you're right that this is kind of a skeleton policy, statement, there's also a whole lot of ways of doing this that are already being done. So like, for example, the board deciding on what's considered essential medical services. That's already being done in the case of Medicare, Medi-Cal, VA systems. Those things are established, and so so it's not like you have to reinvent all that. There's a whole lot of essential worker type activity that's going on, under the auspices of commercial insurance companies that easily transitions into the public health plan under AB 1400. So people who were like what Jeanna does, which is you're facilitating payment to companies. Well, you can facilitate care to patients almost exactly the same way. Make sure that they're getting all of their care needs met, like their diabetic needs, whatever it is. If they need home care, if they need medical equipment, all of that kind of stuff, you can those folks can become care facilitators rather than payment facilitators. So so a lot of that stuff, it makes for rather straightforward transition. And we're not reinventing the wheel, kind of thing. It's not something that once this is passed, a whole lot more work has to be done. Jeanna, you're right. There's a lot of filling in that has to be done by the board, but passing this, sets the stage for all that to be done. And whether it's by somebody in an expert policy position or other people are just more practical concerns, I think it's very straightforward at that point. The big lift is saying, yeah, we could be doing much better than what we're doing now, and getting a general agreement to that effect, which is what AB 1400 is.
Exactly. It is. It seems like it's something so revolutionary, but it's really not. It really isn't. It's kind of common sense that should have been passed while I was in elementary school learning my alphabet. But nonetheless, here I am at 33 years old. We're going to do it now. Better late than never, right?
Yeah, we were talking about COVID. Paul asked a question about single payer countries responding to COVID. And I had mentioned earlier that South Korea just did a phenomenal job in testing, universal testing, right from the start. Everybody knew they were testing as many people in a day in their country, per capita, as we were doing in an entire month, or I think even more, like 3 months of testing per capita, that we were doing, they would do in one day in South Korea. But if I could just share for a second what that looks like, I'm going to show you 3 graphics. Can you all see my screen? So this is the spaghetti diagram that Jeanna was referring to earlier. It's behind me in the background. It shows how the convoluted mess of a system we have for paying for healthcare in this country, it's so incredibly wasteful. And also it hides all those backroom deals and negotiations. So it's not just waste, it's also fraud and abuse, because commercial health insurance in this country is offering us a product based on what our lives are worth to us, not what it costs them to provide that service. That's called extortion, my friends. That's a mafia business model. Your money or your life, is what they're saying to us. And for that, they offer us this. On this side is the Canadian model. You can see it's very standardized, very transparent, very simple. And that's what we're looking to do. Take a huge mess, complicated mess, and make it simple and transparent. And what happens as a result of that is this. And this answers, I think, Paul, this answers your question more directly, which is all of these countries here have some kind of universal healthcare system. And with these are single payer systems. There's also multi-payers that have their commercial insurance companies regulated down in terms of how much profit they can make, and they compete with public plans, places like Switzerland, for example, which is here. Their insurance companies can make, I think it's 4% in profit. Ours make 20 or 30% in profit of what they take in for your health insurance premium. So Switzerland, an insurance company can only make 4%. The rest of it, 96%, has to go to patient care. Okay, that's called the medical loss ratio. So they consider a loss when they have to pay for your care, right? So in the US, because our insurance dollar is so stretched, we pay more. Here's the dollars. And for that, we get less. Here's life expectancy. Okay, so you have Switzerland, Japan, Germany, Denmark, Ireland, Israel, all these countries here, some single payer, some multi-payer with regulated profits on their insurance companies. They all outperform us in general on life expectancy. And here's COVID. You see the precipitous drop right here in the US? That's what happened to us during COVID. We died a lot earlier. Our life expectancy went down appreciably. Here you can see from about 78 and a half years old down to 77. You know, in Japan, Switzerland, Norway, Germany, Israel, no appreciable drop off whatsoever. I mean, their COVID deaths were not enough to change their overall life expectancy. In ours, yes, it did. If you happen to be a Black male in this country, look at that drop off due to COVID. So you can see, you know, when I said we're the gold medalist of poor outcomes, of deaths, of COVID deaths, there's a graphic representation of that. There it is, right there before your eyes. That's how we died due to COVID, because we're giving our healthcare dollars away to this mafia extortion business model that's run by commercial health insurance and big pharma.
Yeah, thank you, Dr. Bill, for that. And like I said, you know, the thing is that the difference in who you answer to. When you're a publicly funded single payer system, just like in other countries, what was I watching? Oh my gosh, it was something on PBS. It was a documentary. And, you know, one of the countries was like, well, you know, we don't want the people mad at us, you know, and that was coming from the government, that we don't want our people mad at us. And I'm like, can you imagine how our government would be if they were worried about us being mad at them? And the same thing with the health insurance industry. They're not concerned about their members being mad. A lot of times, even though we have the opportunity to choose per se, we are mostly tied to an employer-based healthcare system, which means we only can choose within whatever our employer has chosen. And so they may have a couple of options. You could do a Kaiser HMO, you could do an Anthem PPO, seems to be most common around here in California. And, you know, or you could choose some other plan. And so, you know, you have a choice, but your choice is already restricted. And so that is the problem too. And then at the same time, these people, once again, like I said, the answers they're not answering to you, the member, they're answering to the shareholders, the board, and they're worried about revenue growth, projected member growth. Never is it. And I mean, I've heard it, you know, like I've heard it directly into my ears. And never have I, you know, heard them say, well, yeah, they have to say patient satisfaction just because they have to check that box. But when you're in that room and you're looking at these spreadsheets, which they all love so much, it's about growth. And it's about cost savings, and it's about, you know, mainly cost savings. And, you know, it's about, well, how could we save cost here? How could we save cost there? Partially, yes, we do need to look at risk protection. How can we better care for our members to keep them healthier? But then on the back end of that same conversation, they'll go cut a program. that was being used to do that exact thing. Maybe it was, having more staff to do more outreach to underserved communities to make sure that they're getting their medications filled on time. Maybe it was cutting down a transportation program that was being used to take from underserved to their doctor's appointments. So it was like, yeah, we want to see cost savings and we know our patients are at high risk, but we're going to take this program away because cost savings. So you see what I'm saying? It's like they're saying on the front, they're making you see this, right? This mirage here, but in the back end, it's a lot uglier. And if they didn't have to answer to the board of directors, which was answering to the stock market, then I think that I might not even be here. The healthcare system may not be as atrocious as it is, but because we have to, here I am now getting ready to upend the whole thing because they messed it up. But once again, the workers should not suffer due to the bad leadership. So we're looking out for the workers too. All right, I just want to go to Jeffrey's question in the chat from Facebook, where he had said, I watched the master plan of aging make recommendations, or excuse me, I watched master plan of aging, not the master plan, make recommendations of several hundred from 33 people still being involved. I don't see these 32 people of Healthy California Commission coming up with or supporting new plans or hybrid plans. I just want to make sure that
there are not 32 people on the Health California for All Commission. It's 14 people. So not sure what 32 people that Jeffrey's referring to as regards to commission. And the commission is charged with moving forward with universal health care in the state. And they've actually, advised, in the hearings that they're not looking at specific legislation like AB 1400, specific. They're not going to look at legislation specifically. They're going to come up with a plan for the governor. And there's a spectrum of opinions on how to do that. But they're all focused on what they call unified financing as the overall, desired way to move forward, which is single payer. Unified financing means single payer, as is AB 1400 is modeled around a single payer system. So if they're going to have some differences with AB 1400 or not as a result of at the time of the conclusion of the commission, which is expected to conclude by the end of the year or not, is hard to say exactly. The other thing, as I think Jeffrey's aware too, is that, with this recall election taking place next week, or taking place now, that will conclude on September 14th, a lot kind of remains to be seen. If the governor holds his seat as the head of the state government, then we can move ahead with what the plan is that results from the commission report that will be given to him at the end of the year. And that then applies to AB 1400 because AB 1400 was held by the author, Akara, until the end of this year, at which time he plans to move it through the committee process. And so the commission, if it comes up with a recommendation for a plan like AB 1400 or close enough to it, would actually lend a great deal of credibility to AB 1400 and moving that forward through the various committees of first the Assembly and then the State Senate. So it could actually still have a whole lot to do with again, if the governor keeps his seat, is not recalled. If the governor is recalled, the whole thing is blown out of the water. And we're all scrambling to get better leadership at that point again. Even if we don't like the way the governor is handling things now, it's going to be, as far as anyone can tell, a whole lot worse. We're going to be thrown in the mess that Texas and Florida is in right now, if the governor gets recalled in the meantime.
Yes. So if you have not voted, taking a side note, if you have not voted, please go vote. All you do is vote no and go. That is it. You don't have to consider all 45 Republicans on that ballot. Just vote no and go, and keep it pushing. Because, like Dr. Bill said, right now, this has been a lot of hard work. We have been organizing and strategizing on this bill for a very long time. And then dedicating office hours for like 4 months now. And I would really hate to see this go to the wayside, our hard work, because we've gained momentum. We're having really good conversations, and we've been building really good relationships with our elected officials around this bill. And I would just really hate to see all that hard work go to waste because we decided to sit out of this election. So I hate to get on the soapbox about it, but democracy is not a spectator sport. It is a blood sport. And I am asking all of you guys to get out here on the field with me because I'm a little tired. But at the same time, this cannot happen. If we're going to get AB 1400 through, it will have to have Gavin Newsom's signature on it because no other governor will hear it. And then on a safety standpoint, as a woman, it is extremely dangerous. As a woman of color, it's even more dangerous. I don't care if Larry Elder is Black or not. He is not Black by any means, only the color of his skin. But and also COVID, this man has literally said that he on day one will sip his tea, by the way, very posh of him, and repeal the mask and vaccine mandates, and then he's going to go take a break. Those were his words. And so if every progress that we have made will be kicked back by like a foot if we do not, deal with this. I hate that it has to happen. I know it's a great distraction. Trust me, I am not the one that is like out here rah anything. I just really have to emphasize that this is another imperative election I don't want anyone to sit out on. So if you're in California, please make sure that you have voted no and go. September 14th is the last day of the election. It is not the first day. So you can vote right now. So please do. Not to mention the vote, the way you can access your vote, that is at stake. The fact that you got a mail-in ballot and you have 14 days to get this ballot, you have all this time to get this ballot back. That is a privilege California has. That is not a national anything. Other states right now would love to have the privileges we have when it comes to voting. So please make sure you exercise that. Okay, soapbox over on voting, going back to CalCare. I just want to see, Paul, do you see anything in the chat on Facebook? No?
No, nothing right now.
All right. So I wanted to talk about something that I'm in the process of working on. I'm not going to talk from a point of an expert by any means, because if anybody is an expert on anything in this industry, I don't believe you. There's no way to be an expert because it is completely a mess. You might be able to be an expert in one small thing, but to say that hospital-based payments or the payment system of healthcare is completely impossible. Someone prove me wrong, but I've been trying to research this because earlier this week I had a conversation, just a mind of thought that, how does Medicare payment work? I thought that would be a good way for us to discuss like single payer and how does Medicare payment work? And man, did I fall down a rabbit hole. I shouldn't have asked that question. I shouldn't have asked it. I should not have been curious. I know a little bit. I know this much. So that's why I say I'm not coming to you from a point of an expert. I'm coming more of a point of exploration. Medicare has, and it's better than most, don't get me wrong, it's better, but they have prospective payment systems, PPS. And I'll share this little graphic that I was looking at. And I think one of our HCA members, Sarah Dean, has also created a cool little graphic, but this is just strictly Medicare. And here I go with problems with the share screen again. So here we are. So this little cute graphic I saw was about the Medicare reimbursement by provider type. So, you know, you have hospital here, ambulatory surgical center, outpatient, and then you have, you know, physician, like your doctor's office reimbursement. This is Medicare only, okay? But this is also kind of a reimbursement structure and that a lot of the health plans try to mimic, and I could see a lot of our single payer system kind of mimicking. In a sense. So I just wanted to share that in the hospital, you have the DRG, diagnosis related groups, for inpatient payments from hospitals, meaning that, you know, based on your diagnosis, they have already worked out basically a structure of how the hospital get paid, like how many days that person should be in the hospital, the treatment that they should get. These are based on, you know, basic diagnoses and basically your, how do I explain it? See, that's why I say I'm not an expert, because like it is that can get that confusing, but to basically say that, like, if you have COPD, for example, you come in for a COPD exacerbation, a DRG payment will say, okay, based on, you know, all this information they've gathered and studies and things, this hospitalization should be like 3 to 5 days, and you should meet these milestones, right? And that is kind of like how DRG works. So if a hospital is getting paid DRG, if they discharge you, they get you better, you're ready for discharge, you're medically ready for discharge prior to hitting that, let's say, 5th day, the hospital might get a little bit of money. You know, they might actually get to pocket the rest of that. That's okay. Good outcome, because they still have to make sure you're medically stable, right? Because if they do, like, for example, the fail safe on that is that if you discharge and you readmit, they can get dinged on that readmission. So they don't like high readmission rates either, because that's another Medicare outcome that's being monitored. So while there could be, you could wonder why, oh, well, wouldn't they all just want to discharge early to get that extra money? I'm like, yeah, but if you come back in the hospital because they discharged you too early, well, that also hurts. And so that's kind of how like a DRG type thing works. But if you stay sick and you're sicker, then you can go over, and then, like I said, the hospital's losing money. But at the same time, a kind of a fail safe to that part would be that, you know, let's say you had COPD exacerbation, but we found out you had COVID. So now we put the COVID diagnosis in there, and now we have a whole nother DRG set. So there is a fail safe for if someone's sicker than what is initially, you know, documented or initially diagnosed, then you can, you know, add another DRG in there and get, you know, paid for those extended days. So you're not just losing a lot of money on really sick patients. So you see how complicated even this simplified structure is, right? So going back to the spaghetti bowl, now add all the spaghetti of all the different health plans, and just in California on top of this, okay? So we're dealing with Medicare patients, yes, but now we also have to deal with all the commercial plans, all the PPOs, the EPOs, the HMOs, all that spaghetti on top of this. If I could just get it down to this, I would be, man, like even talking to people who aren't even involved in this single payer movement, even just being able to get it down to this simplified structure here would be so much of a breath of fresh air. And so that is where the goal is. It's like, I mean, if I could just get the spaghetti to this part, man, like I'm going to be doing my job so well, you just have no idea. Patients are going to be happy, happy, happy. You go be healthy. So I just wanted to share that. We are trying to simplify here. We're not trying to make necessarily this go away. We do need payment. We do need funding. Yes, yes, yes. We all need that. We're not pie in the sky dreams like a lot of our writer wing brothers and sisters think, that we just think money grows on trees. No, they're the ones that think money grows on trees. But at the same time, we are trying to simplify this healthcare system, because there's not a whole lot of room for error in this line here, right? So you have an ambulatory surgical center, you go for your, you know, you had to have a, you know, maybe a mild surgery that didn't need this level of care. So you had it done at this level of care. There's not a lot of room for waste and things to fall to the wayside when the payment's going straight here, right? Not a lot of room. But if the payment had to go out here to this physician, had to be reviewed by a physician reviewer with the health plan, and then they had to determine which level of care that they wanted to send you to, whether it be an ambulatory surgical center or a hospital. But guess what? You live in a rural environment, so you don't have an ambulatory surgical center within, you know, distance of you. So they want to send you to the hospital, but the hospital couldn't accommodate your care at the price that they wanted. So they sent you to an ambulatory surgical center way out yonder that you couldn't get to. That's what happens now. Same thing for our physicians. Dr. Bill, you know, and our other docs that join, they would love this simplified line, but instead they got to go here, they got to jump around, they got to go down, they got to go down the stairs, they got to go around circles, and then finally get to here, just for them to health plan to say, oh, you forgot to add the 0.002 to that diagnosis code, so we're denying your claim. So they send it back here so that they can add the 0.002 to the diagnosis code, and then they have to go back through it again. That's what happens right now. So I just wanted to share that.
Can I jump in?
Yes, Dr. Bill, feel free.
So you're absolutely right. This is not pie in the sky. Do you know what my next line is? It's Marie Callender's pie. This is pie shop piracy. We're having a third of our healthcare pie is stolen by big insurance and big pharma. You know, a third of every healthcare dollar is being stolen by that mess, the spaghetti bowl that you're talking about, you know, throwing that spaghetti on the wall, that nonsense, that horrendous, you know, mess that we have of a way of paying for healthcare. That is the spaghetti, you know, that means that a third of every healthcare dollar is being stolen away from us. And this simplified system, you know, like they have in Canada, it exists. It's not in the sky somewhere. It's right to our north, in the country right directly to our north, Canada. This is what they use. They save that third of every healthcare dollar. They're able to actually spend it on taking care of patients, on patient care, instead of throwing it away the way we do. A third of every healthcare dollar. So if you think of right now, I like to use the example of a hospital. You know, where I live and work, I'm retired now, but I worked at a hospital that was pretty new. And I was told that brand new hospital, kind of suburban Southern California, cost $1 billion to build a hospital. Okay, one hospital. All right. Think of all the hospitals in California that we have. And think of all those billions of dollars. Now think of that as being only 2/3 of the money we're actually spending. What happened to the other third? And what happens if we put in a whole nother third into more healthcare instead of in the pockets of individuals running those health insurance companies and big pharma? If we actually build more hospitals and clinics and hire more providers and clinicians, I mean, that's what we're losing. We should be hopping mad, angry, as if you went home with a pie from Marie Callender's and you opened the box and a third of it was gone. You know, that's why people should be voting for AB1400, because they are mad as hell that third of every healthcare dollar is being stolen from us. So you're right. These systems sound incredibly complicated, but they don't have to be, and they aren't. In every other country, you know, that's doing systems like this that are simplified, they're standardized, they're transparent. We don't have that in this country. We've let the vampire be in charge literally of the blood bank, you know, and it's time to end all that.
Yeah, absolutely. And that's why I just wanted to share that. Because I asked myself the question. I was curious. And, you know, I know more than people quite a few people in my field that I work with, because I can explain, and they're like, how do you know that? And I'm like, I asked the question, or I Googled it. And, you know, but even still, I get so lost in that mess that I'm like, I don't understand this, you know. And so who does understand this? You know, does anyone understand this? I haven't met one person at all levels that could really explain it to me. And so I feel like we're sitting in is just layers and layers of fluff. That people don't even understand where we are. We are so far gone that I don't think, you know, I mean, maybe I'll have to go digging with HHS. Maybe Xavier Becerra will give me a job that I can go really start asking like, well, if this means that, then why does this say that? You know, like, I don't know. Dr. Bill, what do you want to add?
Well, there is good science. I mean, scientists are not necessarily good policymakers. You know, they like to argue amongst each other. They're kind of like a lot of know-it-alls, you know, and stuff like who's the smartest person in the room kind of thing. You know, so you don't always want them making policy, you know, but there is good science for this. And I don't know if I can share my screen again. Yeah, let me show you another slide. This is a study that was done, you can see in 2004 by an economic analyst group called the Lewin Group. This is an independent economic analyst group. They're considered very independent. They're not right-wing, left-wing, academic, any of that. Okay, very independent economic analyst group. And this was a single payer system proposed by Senator Sheila Kuehl, who was from Santa Monica. She had been on the Santa Monica City Council before she got into the legislature. So it was SB 921. Eventually it was vetoed by Arnold Schwarzenegger, governor at the time. But you can see this shows it saved money for all employer groups, small, medium, and large across the state. It saved money. So this is economic science. You know, when you look at economics, it generally falls under the social sciences group of, you know, academics, right? Because it's talking about the science, you know, how do they determine data of money, of the transfer of money in economies. And here's the science behind a single payer group and how it would save all businesses money, hardcore dollars per employee in small, medium, and large sized businesses. Not just, you know, commercial employer groups, also public employer groups. So let's say you're a school district with many more than 500 employees in your school district, you could be saving this much money. Actually, it's my understanding is that it's probably double this much now. So these were 2004 dollars. As we know, insurance companies are charging probably twice what they did, you know, 15 years ago for health insurance, are charging twice that now for employees through their employer-sponsored plans. So employer groups, including public employees, could be saving upwards of $5,000 to $10,000 per employee per year. You know, and that is science. That's hardcore economic, independent science. And, you know, public health scientists as well agree that we could be saving lives as well as money. So, you know, we know it can be done. The science is clear that it can be done. It's the policymakers and pressure from us, from the public, you know, the grassroots pushing up on those policymakers that has to make it happen.
Exactly. And that is why this is going to be a bottom-up bill. This is not going to be a top-down bill. No one can expect for the elected officials to, even though Ash Kalra, Miguel Santiago, they are taking heat from their coworkers up there in the assembly, but we can't expect them to just be the sole fighters. Like I said, this is not going to be a spectator bill either. You can't just say, oh, I support it, and then expect to have it pass through, because unfortunately it's not. It is going to take all of us standing together, walking and marching together to get this done, because it will revolutionize healthcare as we know it in the United States, not just California, but the entire United States. Because what it's going to send is a very powerful message. Because if you haven't noticed, you don't hear a lot about AB 1400 in the news. You don't hear about it in major news sources either. You don't see it in LA Times. You don't see anything. It's been pretty much crickets. And that is because, I mean, a little bit by design. First off, there hasn't been a lot of movement on it, but there will be coming, in the fall and winter. There's going to be lots of movement on this, and hopefully that gets a little bit more media attention. And then also, thankfully, this is not a ballot measure. We kind of don't want it to be a ballot measure because we know who has the dollars to really put up for advertising. And I am just a poor, broke millennial. So I would prefer not for it to go to the ballot. I would prefer for it to pass through as legislation so that we do not have to fight the insurance industry when it comes for advertisements. We have to fight them already when it comes to just our elected officials. So I'm hoping that everyone that is watching this who is tuned into office hours will be calling their assembly people, letting them know that we are, wanting this bill. We want them to pass it. We demand that they pass it, number one, not just want, we demand, because we are their shareholders. We are their board. And we need to remind them of that, and like in a nice way, we don't have to be so aggressive, just in a nice way, or remind in a nice way. All right, have I missed any questions? Things are a little bit quieter today, which is perfectly fine. It's Labor Day weekend. I hope everyone's, enjoying themselves.
I have a question for you.
Mm-hmm.
This last week we saw at the state level, okay, in other states, not California, thank goodness, we saw states apply really extremely aggressive and repressive healthcare measures on women, in particular in Texas now, applying these draconian measures to stop reproductive freedom and abortion services in Texas. So what's in CalCare? What's in AB 1400 that keeps California, and keeps the freedom of women to decide what their, choices are, what their reproductive choices are, once we pass and implement CalCare in California?
I believe there was, sorry, I'm trying to actually pull up the bill. Oh my gosh, sorry, too many links. What do I have up here? I have too many things up. I'm actually trying to pull up the bill because I believe
Sure. Well, while you're doing that, let me say that I think, I'm not 100% sure, but I think California is one of the states that have, as a state, codified, meaning made law, what the intention of Roe v. Wade was for the nation, right? So Roe v. Wade made it constitutional, even said that the Roe v. Wade decision said that it was a matter of a woman's privacy. I think it's the 14th Amendment applies to privacy for a woman to choose whether she terminates a pregnancy or not. And I think California was one of the states that turned that into law in our own state constitution. So I think it's much easier in California then to extend the full range of reproductive services in our healthcare. If I'm not mistaken, that may even be in our state constitution, but I'm not absolutely sure on that. And I think as you're looking up in AB 1400, I think there is specific provision for that. The other thing that exists in the national that may or may not exist in state is this thing called the Hyde Amendment. Mm-hmm. What was his name? Henry Hyde, I think from Illinois, was a Republican member of Congress who got an amendment passed that said no federal dollars could be applied to abortion services across the country. And I think California said, that's fine, we'll pay for them, in our state. So we basically circumvented the Hyde Amendment in our state, if I'm not mistaken. But to me, that's absolutely essential for CalCare, for our own single payer system in California, that we have abortion services, and the full range of reproductive health services available.
Yeah, you're absolutely right on that. And so yes, in AB 1400, of course it's broad, and under the benefits, it does say comprehensive reproductive, maternity, and newborn care. And so I'm just searching through the bill to see if it, directly discusses things like abortion, which I'm not finding. But I know that if California is a kind of like oh my goodness, Governor Newsom even said it yesterday at his rally. We are a reproductive safe place, a safe state for reproductive women's rights. And that is something I know that he and the first partner definitely focus on. And so, I mean, in AB 1400, it does say that it covers comprehensive reproductive. And like I said, I believe that is very broad. And I can't recall, and I'm just looking through it, just trying to scan through really quick through the rest of this to see if I see it go into more detail here. But I don't see it going into, direct detail about, specific women's reproductive rights in the coverage here. But, like I said, I'm scanning through and I'm doing a control find to see if I can find anything else regarding, reproductive rights. But like I said, if we already have this as part of our services that we provide in California, we're not going to go back unless we do something crazy, like have our governor recalled and let some right-wing crazy person take over who will basically, they probably will cut Planned Parenthood and all of our reproductive services. That's why I say, as a woman, it is imperative that we do not go back to some type of draconian psychopath. And so, but I believe under comprehensive that would be covered because we're already covering it. And so, but that is another thing. Like I said, even passing this means that we are going to have to stay on top of it. We're going to have to stay, on top of what's going on in the bill, the amendments to the bill, because amendments are going to come. What are going to things that have to be removed for the sake of getting it passed? That's with every bill. The ACA is nothing what it could have been if it hadn't been gutted to get it through. It had to take a big hit to get it through so that it passed. So Obamacare is not the Obamacare that was originally written by far. I hope that, and I do not want to see that happen with AB 1400. I'm hoping that because we are a progressive Democratic supermajority state, that won't happen. We don't have to fight the right wing like you do on a national level. So with that being said, though, I think that is a really good question. I think that is something, now that we see what's happened in Texas, that will have to be a little bit harder addressed with this bill and should be focused on a little bit more. Maybe they do need to go a little bit more in depth to make sure that we are truly protected. Because right now, comprehensive could mean a lot. It could mean a little, but it can mean also a lot. Okay, so I just want to go
We do.
Huh?
Well, we do, just to comment on what you just said, we do have a Democratic supermajority, but it's not necessarily a progressive Democratic supermajority. And we have a lot of Democrats, what I would call status quo Democrats in Sacramento, who feel that it's fine to keep things the way they are. In the old days, we used to call that conservative. Nowadays, conservatives mean fundamentalist, religious or whatever. And this, if Gavin Newsom does get replaced by those one or two kind of leading Republicans on question 2 of the recall, is there any certainty that the legislature could gather itself together to oppose a new governor in the 14 months or whatever that they have to still left in the term? There's no certainty whatsoever that they can. So, frankly, that new governor, if there was one, perish the thought, could do a whole lot of damage, which includes, abortion rights and abortion services in California, in my opinion. This is, I think, a huge threat to California. I mean, but definitely across the country, to try and drag us not just back, a century before women had the right to vote, but before even back to the witch hunt, Salem witch hunt days, You know, when women were, you know, were burned at the stake, I mean, and neighbors were pitted against neighbors, and you know, all of that. So I mean, that's what's going on elsewhere, and it could happen here too, if people don't get up and do something about it.
Exactly. It is definitely like we are not safe here. And I, coming from, you know, having, you know, coming from Indiana, is I know the difference in, you know, from California to being under Republican rule to now. And so I can tell you, we are not safe by far. And we just happen to be a little better off, maybe an inch further than some, but we need to protect every inch that we have gained. And that means sometimes we got to support people that, you know, may not have supported us. The governor has not come out strongly saying, yay, CalCare, as much as we want him to. And for that, we are going to push on him for it. But at the same time, I know what's at stake. I know that allowing this recall to happen just because he has not said, you know, he's pro my bill yet, my bill, their bill, our bill. You know, it's not worth it. The damage that could be done is too great to allow that to happen. So I need him there and I need this recall to go away because yes, I do need to harass him and I don't want to feel bad about it for harassing him in the middle of this recall. So September 15th, you keep your office and I shall harass you. And so going to Dennis' question from Facebook, I received a response while CalCare texting this weekend. While trying to answer the how are you going to pay for this question, would love suggestion on a response. I'm sorry. And he puts in quotes, I'm sorry, but that's just not enough information to me. Some combination of progressive taxes tells me nothing. I'm already on Medicare. I need to know if progressive taxes will be higher or lower premium than I am already presently paying. I'm in favor for a single payer system, but you will never sell the idea without solid numbers. Here we go again. So solid numbers, everybody wants to know, how are you going to pay for it? Like I have to show them the damn checkbook ledger. Nobody, and since we're kind of coming up on September 11th, I don't want to compare, but I'm going to compare. Nobody asked how the hell we're going to pay for Afghanistan, except maybe Barbara Lee and Bernie Sanders. And maybe a couple more. I'm not going to cut out people, but nobody asked how the hell we're going to pay for war. Nobody asked that. Nobody asked. But the minute I try to get something for the greater good of the damn American people, I got to show my bank ledger. Okay, I'm sorry. I digress. I don't want to piss people off. I'm really not, but it's just this particular conversation comes up, but nobody asks it when we're trying to blow things up. Nobody asks it when we're making budget cuts. Nobody asks it except when we're trying to help people. I don't understand it. When it comes to the Green New Deal, progressive making aggressive changes to protect our very planet that we have, that's our habitat. All of a sudden payment comes into the factor. But then when in healthcare, when I'm trying to protect people from the next pandemic, which is T-minus ticking, another pandemic is coming, people, and it ain't going to be 100 years, I promise you. I got to show how I'm going to pay for it. But if I want to go blow something up, especially brown people, it's okay. Whatever, wave my American flag. But to answer the progressive taxation, so we have a mixture. What California is asking, which is also written in the bill, which people have heard us talk about waivers. We are asking for innovation waivers, basically saying, hey, federal government, we have an idea and I have a bill to back it up. I'm asking for you that you already give me money for Medicaid and CHIP. I'm asking for you to give me the Medicare dollars. I'm gonna put it in my pot of money, my pot of gold, like the Lucky Charms. And I'm going to add my money that I got from my little taxations. I'm going to put it in this pot too. And I'm going to make this lovely, as my dad would call, goulash of soup, of payment, of monies. And that's how I'm going to pay for this. It's a mixture of the waivers from the Fed, also mixed with the progressive taxation. And that's how we are going to pay for it. And that's why I say, can I give that ledger statement? No. Will I be able to ever give that ledger statement? No. Ask the military industrial complex to give a ledger and we'll see how much they wasted. Just saying the Pentagon lost what, $600 billion or something like that, or 600 million. They lost a good portion of money that they haven't been able to account for. That was your money that they lost, by the way. Lost. So, you know, I think that it's going to be needing to really build it out. Once again, passing AB 1400 doesn't immediately mean that this is going to affect the people right away, unless we can answer that question. So as much as I want to go in depth, I want to be like, well, on month one, upon launch, we're going to have this many expenditures, and we're going to expect to print the CalCare cards, this expenditure, and to print this, we're going to need this expenditure, and the rollout is going to be this expenditure. I wish I could give you that right now, but I can't, because we got to get it built before I can give you the list of expenditures. But you know, Dr. Bill, I'm on a rant, so I'm gonna let you chime in on that. I'm ranting.
So let me talk Bernie to Dennis, because I know he understands Bernie too. So I know you do too, Jeanna. But what does Bernie say about Medicare for all? Because it directly applies here. I mean, the economists, you know, who have projected savings for national Medicare for all will also project savings for California, you know, AB 1400, once we accept those, you know, economic feasibility studies, like the one I showed earlier, that graph that was done in 2004 by the Lewin group. You know, last time for SB 562, it was the Perry group. So what does Bernie say about national Medicare for all? He says it'll be between $8,000 and $10,000 in your pocket. $8,000, $10,000 raise that you will get in your income once you have the single payer healthcare. And why is that? Because what you pay now through your employer, or what you pay in, say, you know, Medicare supplements, what you pay right now out of pocket for healthcare, you know, on average means that you're going to have a raise of thousands of dollars of personal income once we go to a single payer system. Every person who is, you know, who gets healthcare, you get all the healthcare for no out-of-pocket expenses, no point of service, you know, it costs you nothing at the point of service, no out-of-pocket expenses at all. And you get this raise in your personal income as a result. So I don't see what's not to like there. That's how we're going to pay for it. We pay less than what we're paying now. You get a personal raise, and we get all that health care as a result. Okay? And you know, the rest is up to those policy wonks who can figure out if they can sit in a room, decide who's the smartest person in the room, and then just go ahead and develop that you know, that system. It doesn't really matter to me how they do it, as long as it's fair, it's equitable, but it ends up saving everybody money and gets everybody health care, because that's what we know after years and years of looking at this. They've got models around the world that they can model it after, which, you know, it works extremely well, better, you know, of course, than what we have now. Pick any of them. It's going to be better than what we have now, or all of them.
I mean,
which they certainly can
take a piece from every country. Oh, we like this about Taiwan. Okay, Japan does this well. Luxembourg, who I think is still #1 in healthcare, does this well.
Go for it.
Literally build the dream healthcare system.
Go for it.
By just stealing pieces from other systems.
And I mean, really do it yesterday, okay? Because people are dying right now. So
people are dying.
You know, that's right. And there's money to be saved that could then go into not just your personal pocketbook, but also how many of those school employees, you know, can we save $10,000 per employee per year that can then go to school expenses? How many city budgets can then have that relief so it can go into, you know, affordable housing and infrastructure for cities? All that stuff right now is going to the pockets of CEOs and shareholders of these commercial, you know, captains of industry, quote unquote. You know, they don't really make it. I hate to call them the insurance, industry, because they don't make anything. Industries make things. Insurance doesn't make anything. It acts as a risk taker, as a risk pool, holder of money. Okay, banks can do that. The public can do that. That's what we're talking about. The public assuming that role does not need to be done by commercial interests. And that's what we're talking about. We're talking about saving all of that overhead, that 20 to 30% profit that insurance companies are making. A traditional Medicare operates at 2%, not 20%. If all those people who are fans of making government work like a business, government should run like a business. Okay, which business do you want to have? The one that runs at a 30% overhead or a 2% overhead? Okay, that's what we're talking about here. So that's how we're going to pay for it, like a business at 2% overhead instead of the 30% that we have now. So pick any one of those answers, Dennis, and thanks. It's a great question. I'm willing to jump on that question anytime anyone puts it in front of me.
Yeah, and absolutely. I just want to answer a part of it where she's saying she's already on Medicare. So you're a senior, mostly, or but the thing is that you have to still pay premiums under Medicare, at least 140 something a month, unless you are considered, low income Medicare and you have Medi. But for the most part, you're at least paying 140 something a month. That is going to go away. Under CalCare, we're going to take the money that the state gets reimbursed from Medicare, and we're going to cover you more than what Medicare covers now. If you have Medicare, straight Medicare A and B, you don't have Part C, you probably, unless you have a buy-up, you probably don't have vision, you probably don't have dental, audiology, long-term care, so all of those are uncovered for you right now. And under CalCare, they're going to be covered, and you're not going to have a premium because we're taking that money and putting it all in one pot. We are becoming a collective bargaining unit. We're going to bargain down these costs, and we're going to cover you. So that's one selling point, because we're not going to be able to give them an exact number. They want to see an exact number. Well, ma'am, you're going to be charged $105 a month. That's what they want. They want to hear that, and we can't give that to them. But I can tell you that you will be covered more than what you're currently covered under Medicare. Because I see it all the time,
No co-pays, no deductibles, no supplemental, no out-of-pocket expenses whatsoever.
No need to get the AARP buy-up plans, none of that.
Just like the vaccine, all of your healthcare, just like the vaccine. You make an appointment, you walk in, you get all of your healthcare. Never anybody asking for, a credit card, an insurance card. Your insurance card could just have your medical records on it. It doesn't have to have anything else on it. It could have your, ID information on it. That's it. Doesn't have anything else on it. There's no eligibility. There's no enrollment period, right? You don't have to enroll. There's no expiration for your enrollment. As long as you live in California, you're enrolled. That's it. I mean,
everybody in, nobody out. As long as you have a body and you're a resident of California, you are part of like I said, celestial beings, aliens of from a different galaxy. I apologize. You can become a California resident if you want, and we will cover you under CalCare. I don't know how functional that will be. But
amphibians are not included.
Amphibians are not included. I'm sorry. CalCare does not extend to pets yet. They will in the future.
Newts and salamanders. Sorry.
Sorry.
But I would like to jump on at the very beginning when you were talking about the 7 principles. This notion of freedom of choice of provider. You're no longer going to be told who you have to see, your medical provider. It's going to be your choice, not your employer's choice, not the government's choice. nobody but yours. You can take the word of a fellow family member or a coworker or a good friend. Say you move into the area. Well, I just moved not too long ago. I was looking for a dentist. You want to ask folks that you know in the area, who's good here, and that's who you can see. You can see them. And guess what? If you go see them, you don't like them, you just go see someone else. You have complete what we call laterality. You can make a lateral move to anyone that you want based on your understanding of what their reputation is as a medical provider. So that could be someone who's very trusted individual solo practitioner. It could be a big institution that you have all kinds of respect for the research that they do. That's your level of comfort. You can pick within that range, depending on your own level of comfort. It's no longer some network that someone told you have to be inside of. That's real freedom. That's something Canadians have that we don't have in this country. And there's no reason why California, the 5th largest economy in the world, can't have that kind of freedom either. So just want to emphasize that point, Jeanna, from your presentation earlier.
Yeah, thank you for that. And absolutely. And I know it seems too good to be true. It seems real pie in the sky. And that is because we have been bamboozled. That we have been told that the more we pay, the better the care should be, right? And that's not the case, unfortunately. But I want to go to Jeffrey from Facebook. He said, yeah, it's weird. Hundreds of millions of Americans pay into Medicare every Friday, and people who are supposed to be less evil keep asking how you're going to pay for that as well. And exactly, how do we pay for Medicare? And that is something that's actually on the conversation. Social Security and Medicare, they have realized that a lot due to the pandemic and, the pot's running out, basically. Social Security, I read, is good to 2034. And after that, well, that's going to depend on who we elect, really. If we continue to let moderate to right-wing politicians in our positions of power in Congress, then I could say Medicare or Social Security may not make it to my generation when we will need it. And so that is, a part of why we have to. Everyone's political, basically. I can't emphasize this enough that democracy is a blood sport. And the reason why I say blood sport is because, yeah, you get hit. And it's a contact sport. You take some losses, you get banged up pretty bad. I've got some scars already. But at the same time, we need people out there, because the more we continue to watch it and just, watch it be a spectator, is how the right wing continue to take over. They know where to hit us. They know how to manipulate. They know how to run narratives. And one thing is that they just have a hatred for everything, and that keeps them unified. And so, I can't emphasize that enough, that our Social Security, our Medicare is under attack. If we get AB 1400 passed, we will continue to have to fight for it. Even if it's passed, we will continue to have to vote for politicians who are going to support it, who will keep it going. And that's why they say democracy is not a spectator sport. Because, yeah, we are really much so always going to have to be keeping that in mind. But that's what makes democracy, is that the people decide. This is for the people. And for too long have the people been too silent. So we will have to stand up.
Can I commend you for that position, Jeanna, as a healthcare provider and professional yourself and myself? People think that we are healthcare people are not generally politically aware, and you are an exception. I'm an exception, apparently, because ultimately everything is political, and all politics are local. It's politicians at the local level that usually are rewarded for their good decision making by going to higher office, right? So we need to grab them when they're on city councils and school boards and say, what's your position on, on single payer Medicare for all, on CalCare AB1400? Do you know how much money that's going to save for your school district, for your city? What you can do with that money for your city? Shouldn't you be supporting that? Shouldn't you be pushing our representatives in Sacramento so that then would have that kind of impact in your city, so that we can get healthcare to everyone, so they can be healthier, happier. We can put more resources into preventive care and keep healthcare costs lower as a result, and have better healthcare outcomes as a result for our community. So that is so important. You're absolutely right that politics and even the politics of healthcare cannot be a spectator sport. And all healthcare people who are interested in healthcare, and especially public health, should be politically aware and politically engaged. So I just want to thank you for that. You might feel like the Lone Ranger sometimes, but I for one believe in right there with you. So,
oh,
thanks.
I thank you. And I think, dealing with, I know that it's more than me out there because I see it, I see it through doing stuff with HCA, PNHP, CNA, we're all out there, even though, yes, we are a drop in the bucket compared to overall California, we need more support. Absolutely. But at the same time, I can't emphasize enough how much this needs everyone's participation. And it's just as simple as voting, as simple as asking, do I like this single payer thing? Do you support it? Okay, great, I'll vote for you. Simple. It's really not that complicated. You do not have to dedicate your life to this. I keep emphasizing that. I'm just weird like that. This is my social time.
Somebody for city council will say, well, that's a state or federal thing. That's not a city.
It's their thing. And that's why I want to give a shout out to Cheng Sim and Sean Broadbent for getting this through, or helping getting this through the LA City Council. Yeah. Los Angeles City Council approved this resolution supporting this bill. And it's coming through city councils and neighborhood councils. We are pushing bottom up to the assembly with the pressure here. And not to mention, I think the resolution passed, I think, with everybody, all members. So, I'm putting that out there, like, even my more moderate people on LA City Council said, okay, so you're held to it now. You are held to this.
So go to those town hall meetings, and when they're holding a coffee group somewhere, or a meet and greet, a candidate holding a meet and greet, and ask them. And it could seem ridiculous even to some people. They want to talk about zoning laws or potholes or whatever they want to talk about. But you can say to them, hey, what do you think about this universal health care law? And wouldn't that be good for our city, our school district, and just tie it together with that simple question. And if they haven't thought about it, if they're not aware or haven't thought about it, then shame on them. Maybe they can come back the next time with an answer to that question.
Absolutely, because I believe that healthcare is one of your constitutional unalienable rights, which is your right to life. If you are not healthy, how can you live? And
that's right.
And don't get me started on the Constitution, because I kind of don't believe that the Constitution was written with me in mind, because it said all men, and I don't think they were talking about men of color either. But nonetheless, that's a whole nother conversation for a whole nother office hours, which is not involving healthcare. I just think that, though, it is an unalienable right, because if we are not healthy, how can we live? But I just want to
life, liberty, and the pursuit of happiness.
And the pursuit of happiness, and all of that goes back to being healthy. And so I want to just go back to Carla Mays from Facebook, who asked, who is talking to Gavin Newsom about this? Well, we kind of all are subliminally. We're tweeting him. Has any of us had a time to sit down with him? No. Has he accepted my offer for a date to In-N-Out? Not yet. But we are trying to get his attention. I do believe we have a few
French
people.
laundry. The in and out one, it's got to be French Laundry.
No, there is nothing more Californian than in and out. It is in and out. It has to be. It's a good PR opportunity. He can take it. And so there is nothing more Californian than in and out. And so, but you know, I think that we have to show it's not really on his radar yet, honestly, because he's waiting to see the outcome. Will it make it through a committee? I think that once it makes it through committee, in January, that's when it may start to whistle in his ear a little bit that, okay, maybe this is coming. Because if you keep in mind, you know, AB 1400, it has to go through committees, then it has to pass the floor of the assembly, then it has to hop over to the Senate where it has to do the same thing, getting through the committees, and it has to get through the floor vote. Then it comes to his desk. So he has some time to kind of just like meander it. But he knows it's there because actually yesterday, thanks to some of our HCA members, Betty and Michelle Verne and Jason, unfurled a nice big banner while he was speaking that said AB 1400 across it. And there was no way you could not see it. So he knows that we're here. He knows that we're making noise about it. And that noise is going to, you know, get louder as we get closer to this. But we also know that pressuring Gavin will help in the sense that if he were on board, he could tell everybody else to get on board too, and they would fall in line, which will make this so much easier. But at the same time, I got to get this through health committee. So I need to get to Jim Wood. I need to get to Chad Mays. I need to get through the health committee members. I need to get through the appropriations committee members. And so, you know, because he could take the easy road out and say, yay, I support it, and it not get through committee. It never gets to his desk and I'm dead. So, you know, like I can pressure him, but I also got to pressure the people, the signatures that have to be put down before him too. So it's kind of a dual strategy here. We're pressuring him, yes, but at the same time, we got to get it through these committees in the Assembly and the Senate and those committees and into the floor and into his desk. I'll give him the pen to sign it though. All right, go ahead, Dr. Bill.
Well, I'm going to chime in too because I know Carla real well too for many years now, and I know that she knows that that pressure comes from the bottom up. And Gavin knows fully well that the vast majority of Californians even are on board for a single payer system for California specifically, not, you know, let alone the rest of the nation. And that Democrats across California are especially on board, like greater than 85% of Democrats are on board. And we've passed resolutions through the state Democratic Party, you know. But what we do have are holdouts in the legislature who are taking big bucks from the big money interests of big health insurance, big insurance, and big pharma still in Sacramento. They are taking the big bucks. And what they're saying is that if they don't take that kind of money, then they run the risk of their seats being threatened by Republicans with big bucks who will come along and steal those seats in the next election cycle. So that's what we have to show them, that the money only gets so far in elections. You need people, you need votes. So it comes down to it, Carla, as always, we have to show that the people are on their side and not just Gavin's side. We're on the side of Jim Wood, we're on the side of Richard Pan, you know, we're on the side of whoever wants to run on our issues. We're on your side. You know, we have terrific candidates now running who are champions of single payer, like Pilar Shivo, who's running for assembly, like Dave Jones, who's running for the Senate now to take the seat of Richard Pan, who's termed out this time. So they are terrific champions of single payer system, and we should get behind them. But even, you know, someone like Jim Wood, I think, is starting to sound like he's more on board than he's ever been, and that's because we're showing them that we will support them for doing it, for being on the side of this issue, on the side of the people. Because if we have enough people, that will outweigh the influence of the money. And that only works if we can get everybody involved and be in the fight, in the struggle, side by side, along with us.
Exactly. And I think that that is the strategy we're going with here. We're not necessarily going on the attack, you know, to pressure people to support this bill. Yeah. But we are trying to let them know that we are not asking for anything unreasonable. We're just asking you to do your job. That's it. Yes, this is going to be an unprecedented, heavy undertaking. Whoever gets assigned to that board, man, you've got some long nights on you, but it is worth it. And if you're not willing to do that for the sake of 40+ million Californians, then I kind of don't want you doing it. I don't want you representing me. If you're not willing to put in the hard work, then why represent me? And that's basically what I'm saying. But if you're willing to put in that work, I have no problem with you. You know, that's that simple. But you're not willing to put in the work, and that is the problem. You're trying to pacify me. You're trying to tell me that there's, you know, other options, or we need to just focus on this or focus on that. You're telling me that I'm not willing to put in the work. And I've put in countless hours for free for this. I don't get paid. You know, I put in countless hours for free. So we're asking them to put in the work. And just thank you, Paul, for adding a couple more candidates who support single payer here in Southern California. We have Getro Elise in the 38th Assembly or 36th Assembly District. And then we have Fatima Iqbal Zubar, there we go, for State Assembly down in 64, which is South Central Los Angeles. So, you know, big shout out to them running on a progressive, you know, kind of innovative, you know, that's the thing. I don't just want people who say I'm progressive. I want you to be innovative. And support, you know, innovative legislation like AB 1400 that addresses a problem, that sees a problem, that sees that this problem is not going to get any better with just more Band-Aid legislation and upends it and rewrites it. That is called innovation. That is what I thought America was supposed to be about. But I guess not. I think it's about Band-Aid healthcare now. But
you're right. Big problems require big ideas and big leadership. So that's what we
So yeah, so more to come from these candidates. You know, maybe they'll pop in on office hours. And as we're coming to a close, like I said, you know, before, it is really imperative that we, you know, educate ourselves to make sure that we know as much as possible. Because if not, that's how we get taken advantage of, is when they take advantage of our ignorance. But we will be ignorant no more. We will not be uneducated. We will know what we want, and we are very well aware of what it takes to get there. We just need them who are in the spots to make the votes. So with that, you know, I'll end this a few minutes early. This has been CalCare Office Hours from Healthcare for All Los Angeles, PNHP. I want to thank you guys for joining us for another segment. It has been a great conversation. Those of you watching who haven't gotten a chance to come on in and join us, ask a question. Things are going to be heating up soon, and you'll be hearing about this a lot more. So, but just know that we are always going to be here to answer those tough questions that you may not have an answer for. So thank you guys once again, and you guys have a great, safe weekend, okay? Bye.
Thank you, Jeanna. Thank you, Paul.
Thank
Thanks,
you,
everyone.
Dr. Bill.
Thanks,
Thank
Dr.
you,
Bill.
everybody.
Signing off.
See you next time. Stay healthy.